My name is Robert Riddell and I'm Professor of Pathology at the University of Toronto in Canada, and I'm a pathologist at Mount Sinai Hospital in Toronto also. I've been invited here very kindly by Professor Zamboni because there is an inflammatory bowel disease conference. So I've been asked to say a few words on the role of pathologists in the diagnosis of inflammatory bowel disease. So they have several roles. The first one is in differential diagnosis and the diagnosis. So patients with inflammatory bowel disease often present with bloody diarrhea, blood in their stool, and or abdominal pain, or both. And so the first question pathologists get asked is the cause of this inflammatory bowel disease or not? And if it is inflammatory bowel disease, there are two major subtypes, ulcerative colitis and Crohn's disease, and we can help distinguish those two, especially when they only involve the large bowel. To do this, the clinician does a colonoscopy and takes multiple biopsies. Those are tiny pieces of tissue from the terminal ileum, the last part of the small bowel, and around the large bowel, and they get sent to us, and we look at the changes in those biopsies to make the diagnosis and to answer those questions. If patients have inflammatory bowel disease, they are then treated and followed up with appropriate therapy, and the pathologist then may get further biopsies at the follow-up, but the questions are slightly different. The questions then are, is the patient responding to therapy, or if not, is there a good reason? And some patients have, for instance, infections superimposed, and pathology can help diagnose some of those. In patients who are in complete remission, which is what we hope they will do, there are also indications that they may be at increased risk of undergoing relapse, and changes in the biopsy can indicate that increased susceptibility to relapse. Now that becomes important because when patients are treated, some of the therapies can be slowly reduced and to very low levels. But if those changes are present in biopsies, it would suggest that because the patient is at increased risk, that their medications should not be further reduced. Now, unfortunately, one of the other complications that we see in patients with inflammatory bowel disease is that they can develop carcinoma, and they develop carcinoma at a much increased rate to the rest of the population. And both clinicians and pathologists try and anticipate this by taking biopsies around the colon and also for looking for lesions in the colon that might be the earliest stages of carcinoma. And when those are found, we can diagnose those as being pre-malignant and sometimes early invasive lesions, and these can be treated very early on so that the patients do not develop full carcinomas and potentially die of their disease. So the role of pathology in inflammatory bowel disease is to make the initial diagnosis, to ensure that therapy is working and perhaps suggest why it not be working, why patients may undergo relapse, and to help prevent them developing and dying from carcinoma.